just wanted to welcome everyone and apologize for a bit of a delay. Sometimes we all have some technical difficulties, so I totally understand. Good afternoon, everyone. My name is Olivia Hensey from the New England QIN-QIO, and I'll be your moderator for today's webinar. Thank you for joining us for a partnership to successfully increase smoking cessation intervention within a community. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation, and we'll take questions at the end, and I'll provide you instructions on how to unmute your line. We'll also be conducting some polling questions, so be sure to answer these and make sure you press submit when they come up on the presentation. And we'll instruct you again how to do that when those polling questions come up. So at this time, I'd like to introduce today's host, Georgette Verhelli, who will introduce our speakers. Georgette has more than 30 years of experience in healthcare. Her varied background has included working in hospitals, primary care, skilled nursing facilities, home health care, and quality improvement. Georgette, the floor is all yours.
Thanks, Olivia, and thanks for bearing with us, everyone, as we work through these technical difficulties. I hope you can all hear me okay?
Yep, we can hear you.
Super, thanks, Olivia.
Okay.
So we'll move on with these slides. Okay. You just passed me the ball. You don't want that. All right, I'm going to do that. I'll pass it back to you, Olivia. Thanks.
Okay, no problem. Perfect. All right, go ahead. I'll advance to the next slide for you.
Super, thank you. All right, there we go. So a little bit about us. We're the New England Quality Innovation Network, Quality Improvement Organization. We consist of two parent companies, I guess you could say. Health-Centric Advisors out of Rhode Island actually holds the contract for all of New England, and they focus in Massachusetts, Maine, and Rhode Island. And then Qualidyne is out of Connecticut, and their focus areas are Connecticut, New Hampshire, and Vermont. Next slide. So if you want to learn more about us, you can visit our New England QIN-QIO website, and that's at www.healthcarefornewengland.org. And when you get to the website, you go to the section you see that circles in red for providers, and that will get you launched into everything that we do and all of our different programs, and also you can look at some of our past webinars or the podcasts and other things that we offer to people in New England. Next one. So I'd like to next introduce you to Jennifer Gullison. She's the chronic care specialist with Cornerstone DNA, and she's going to talk about her smoking cessation copy project. So Jennifer, the floor is yours.
Thank you, Georgia. Olivia, am I going to take the slides, or are you going to keep them?
I just passed the ball to you, Jen, so go ahead. They're all yours.
Okay. So just a little bit about Cornerstone DNA. Cornerstone was approached by the New Hampshire Department of Health and Human Services about the Million Hearts campaign over a year ago. There was a task force aimed at implementing the Million Hearts strategies within Cornerstone DNA. And the state was also working closely with Georgette from the QIN-QIO, which also led us to develop a relationship and work closely together to implement this project. Both the state and the QIN-QIO collaboration was key to the success of smoking cessation, which was our first project within Cornerstone for the Million Hearts Initiative. So this is just a polling question. Is your agency involved in the Million Hearts campaign?
So we can ask Brandy to go ahead and open up that poll. Perfect. So people have 30 seconds to answer that. Make sure that you press submit. Thank you.
And do you see the results, Olivia?
The results may have not come up yet. Sometimes it takes a little while for the results to come up. We'll just give it about 10 more seconds if that's okay. Oh, there you go.
Okay. So it looks like the majority of people are thinking about it, and it's, 25% yes, 25% no. So hopefully after today's call, more agencies will lean towards the yes. So as far as getting started, Cornerstone selected smoking cessation as our first initiative, and the major reasons for that was within our community and even within the organization, there was lack of knowledge about resources for patients. So it's not that clinicians wouldn't ask patients if they smoke, but if they are current smokers and have been smoking for a long time, clinicians didn't feel confident enough to be able to say, well, I'll help you quit smoking, and these are powerful resources to be able to help you along that way in that journey. So that was a barrier within our own organization. And then clinicians are also, as far as confidence, they're unsure how to approach the subject with patients, especially if they've been smoking for a long time. So that's the main reason we started with smoking cessation first over the other aspects of the Million Hearts Initiative. And through continued partnerships, Cornerstone was connected with, again, the New Hampshire Tobacco Prevention Program and organizations like the QIN-QIO. And then we also were able to find additional resources within our community because we not only work with New Hampshire, we work with Maine. So we had to reach out to Maine and find out what resources they had. So it really was a collaborative effort with our home care agency and then developing relationships within the community, which was very successful and rewarding for our organization and our patients. With the implementation, Teresa, who will be talking next, she was able to perform 2 on-site visits at our agency, and that really was beneficial to increasing awareness for our staff. All of our professional staff know about, the effects of smoking and the negative effects on health, but not really the statistics within our own state, resources available to really be able to give them to our patients and connect them with the right people to stop smoking. And with those 2 on-site in-services, it was a multidisciplinary approach. So it was not just nursing. It was our PTs, our OTs, we had LNAs, and our social workers all attended. And they really came out of that in-service with more knowledge, especially about the statistics individual to New Hampshire and the different resources and funding that the state of New Hampshire gets and how that money is allocated and where it's not allocated for smoking resources. And what's key is getting the clinician buy-in, so we really did not have a barrier for any clinician saying, why are we doing this? Because it's common sense. As a professional, we want to give and connect our patients with the right resources. It's something that's going to overall benefit their health. And as long as internally you develop a structure that's easy for them to document and for internal people to track, it is very easy overall and was for us to do. And you must tie the agency targets directly to patient care. So the outcome is not just another thing that we're implementing within the organization, but the outcome is it's going to help your patient, it's going to help them live longer, it's going to help them and their quality of life. So we had to identify a key manager to track and enter the patient data, which we're going to get into. And in our agency, we chose our staff education manager because she was key with the implementation and making sure clinicians attended the in-services that Teresa did here at the agency. We made sure that any clinicians that did not attend got one-on-one follow-up and training as far as what our standards were going to be within the organization. And that person has to be able to be accountable and make sure that every month the data is collected and inputted into the system. Initially, we took some time to figure out where all the resources were. That was a major barrier for us, and I can see it being a barrier for other organizations when you're getting started. And we did a lot of research, and on the website for the HH2I, there is a roadmap to success for implementation and includes a checklist. And tying it all together, that was done after we were able to implement our first smoking cessation part of it. but that really was a very key
In home health care services, VNA Community Healthcare also provides psychiatric home care nursing. We have an experienced staff of psychiatric RNs who offer home visits 7 days per week, along with 24-hour phone coverage. Find out more about these services covered by
Jennifer
and other insurers
Yep.
throughout our
Can
New
you hear me?
Haven, New London, and
I can hear you, yes.
when we
I'm going to mute all participants.
Okay.
If you could just press pound 6 in a minute, you can unmute yourself and hopefully that will deal with the issue.
Okay.
In order to avoid an elder care crisis, it is the leader has muted your line. To unmute your line, press pound 6.
If you want to press pound 6 to unmute yourself.
Can you hear me?
Yep, all set. Sorry about that.
Okay, that's okay. So for implementation, you need to know what data you're going to collect based on the measure that you choose. So for smoking cessation, there were 2 things that you need to collect. So you have to identify was the patient screened and was smoking cessation education provided for at least 3 minutes during the episode. So that's not an OASIS question. Those were measures that were not typically in our EMR system. So we actually we created templates within our clinical notes that capture key information. So clinicians just pasted the template in their clinical note, and it was a simple yes or no. Was the patient screened? Yes. And then we created an intervention under our care plans that was customized, that they selected if the patient does smoke, they can add that intervention. So it was very easy things for the clinician that didn't create a lot of time, and it's something easy that the person who's tracking it has to be able to know exactly where to go to capture that information to be able to put it into the data registry. So by doing those 2 things, it made our staff educators' life very easy, and it was very minor to the clinicians, and they've been able to do it successfully. And with also implementation, the New Hampshire Tobacco Prevention and Control Program was able to customize. They use a referral form. So Teresa was able to, in an electronic version, customize that form so it includes the agency name, agency address, phone number, the key person to contact within the organization. And I have it as myself, but you could use the lead person that's actually inputting the information into the data registry. And we have it also for the customized internal where it's electronic, so the clinicians can just type on it, fill it out, it goes to the person within our organization that does all the faxing, and then she is able to send it out to the appropriate person. So having access to resources that directly benefit patients and through the partnerships, those really were the 2 key things to make this project successful. And again, it's looking at your internal processes to streamline it and find the easiest way to collect that data so that it can be inputted into the data registry. So this is another polling question. Is your agency currently participating in the smoking cessation activity?
So again, Jen,
a couple more seconds.
Exactly, yeah. Looks like everybody may not have pressed submit, and when that happens, we have to wait a little while longer, but it will come up momentarily.
So it looks like about 21 are yes, 14 no, and we have 7 thinking about it and some with no answer. So it's great to see that some are on the line that have implemented the smoking cessation. So when it comes to the questions at the end, if anyone wants to share any additional information as far as how it was successful within your organization, that would be great. And then evaluation. Like anything that you implement within an organization, you have to have the means to evaluate it to see what's working and what's not working. The staff educator brings direct concerns directly to me. So, for example, in the beginning, not all clinicians were using the correct template, so we were not able to capture whether the patient was screened or not. And in addition, not all clinicians would add the correct intervention, so we had to pull all the clinicians together again, do further education, and with the monitoring, which we have to obviously do monthly to input the data, we were able to we've had no issues as far as continued trends in that area. And then you can also monitor the results on the QI reports, which we'll talk about. These are the reports that your agency can run monthly. And if you look at this, we started back in June of last year, and we had a compliance of about 75%, where you can see it started to go up. You can see where it dips. And this is good to share with staff, so our staff educators able to send this out monthly saying, you know, you guys are doing a great job, you have 100% compliance. If we see a month that dips, then we can look at either bringing the clinicians back in to re-motivate them, because sometimes, like, I know my agency's not alone, you implement a lot of things, and healthcare is changing, and clinicians can sometimes get overwhelmed, and they lose focus of some of the interventions that have been implemented in the past. So we haven't had to recently do any refreshers with this because, like I said, they are consistently using the template and adding the right intervention. But if we see a dip in those areas, we will do re-education. So these are good to show staff, to reward them, and also to monitor your progress. So I'm going to pass this over to Teresa. How do I get back to be able to pass the ball?
Jen, if you just grab the ball with your mouse and click and drag it next to Teresa's name, you'll pass the presenter privileges over to her. And Teresa, I'm not sure if you press #6, but if you could press #6 again to unmute yourself.
And I just passed it. Can you hear me now?
Perfect. We can hear you. Thank you. All yours, Teresa.
Right. I'm just going to do a little test here. Okay, so let's see, to advance the slides. Oh, there you go. Perfect. Okay. So I'm going to go back here. My name is Teresa Brown. I work for the New Hampshire Tobacco Prevention and Cessation Program. I'm very pleased to be presenting to all of you today. I hope what I have to say is informative, and I just put a quick slide in here for learning objectives, which is sort of general practice for us, and I'm going to go over the landscape in New England as much as I could get hold of data for, and then we actually have the BRFIS data analyzed already for our 2015. It's not out there for a lot of other states yet, but our EPIs happen to jump right on this for some reason. I want to just go over some evidence-based treatments for tobacco dependence and how we got here, and then talk about state quit lines, which is a wonderful resource and very underutilized in most every state. So this slide is a little bit hard to read, but I wanted to just put it out there in terms of the states that were participating and get a little snapshot on the same slide. So as you can see, not hard to see, the burden of tobacco use and dependence is, it's staggering between the cost and the healthcare cost, the economic cost, and out there. So these numbers aren't 100% accurate only because this resource had not accessed the 2015 BRFIS in all the states. The next slides that I go through will be a little more specific to New Hampshire, but just some general information that I give. So in New Hampshire, just showing the trend of adult smoking rate over the past, since BRFIS changed its data gathering. So between 1965, when the first Surgeon General's report that actually warned about the health hazards of smoking, and today smoking rates have clearly dropped from 43% down to what it is today. And, it's now remaining fairly stable. And there's no magic bullet, according we know that. And every time we figure out a way to help people quit, the tobacco companies come back with a way to help people, access more tobacco products. E-cigarettes, prime on the list. So as a tobacco control program, we have strategies and policies that hopefully drive quit attempts. And the best practices that CDC pushes forward are tobacco tax increases, smoke-free indoor air and outdoor air policies, mass media campaigns that encourage not only prevention and promote quitting, but using your state resources, the state quit lines, and then more restrictions for youth access to products. And I don't know if you know this or not, but there are many states. It's kind of a trend that's going forward about raising the smoking age to 21, and that's passed in a number of states. So youth access is a huge deal towards prevention. So tobacco use in New Hampshire, like who are these people? And this is just, in New Hampshire, 16.9%, and that rounds out to about 181,000 about. So here's information from our Burfus, and so in terms of income, you can see, and this is across. This is national. I mean, this also is national, so maybe little different numbers, but basically, this is not. This information that I'm showing the next few slides are basically across the board. So those who make little money tend to have high smoking prevalence. Again, less than a high school education, high school or graduate, GED. Those are very high levels of smoking in there. By age. Again, tobacco companies are targeting the 18 to 34 range. So, when they're targeted in the colleges and those who have not finished high school, those kinds of things, then the young adults are seriously being targeted by the tobacco companies. So there you have it. Their target audience is taking me off on it. So in New Hampshire, again. These are our figures, but again, it's not so different amongst the states that between the healthcare costs and the loss in productivity when you're looking at workforce, it's huge losses to every state, particularly to huge healthcare costs and losses to states. So why is quitting so important? If you look at the health of the population. Reducing tobacco dependence is a public health priority and a goal for every state's tobacco control program. Science, knowledge, expertise are really all underutilized when it comes to treating those who are tobacco dependent. So there are resources out there, and like Jen was saying, they're little known. So to take my dog and pony show on the road as much as I can is a great opportunity to help people realize there are resources out there that are effective. So one of our goals is increasing utilization of our resources will, over time, improve the health of the population and hopefully reduce the costs and the staggering costs of that. So this is what I call our Bible. A research committee was appointed by the United States Public Health Services, and they reviewed and scored about 6,000 tobacco treatment research articles for relevance and strength of evidence. So this publication is basically a gathering of a summary that states the best practices for tobacco treatment and, the interventions that any kind of healthcare provider should be using. And basically, you can put it as a dose response. So your dentist, your primary care, your OBGYN, your behavioral health counselors, every touch that anybody has really helps that they ask the question in a caring way. How can I help you move towards quitting? How can I help you decide to make a quit attempt? And one primary message for increasing the likelihood of successful quitting is to remove barriers. So, cost, transportation, those kinds of things. And that's what QuitLine's really all about. So this book, and you can access it online at cdc.gov. You can access it online. You can go to our website that I'll show you later. We have it on our website as well, a link to it. Behavior change coaching, medication, use of QuitLines, all those evidence-based treatments are listed in this book. And my copy of this is so dog-eared it's not even funny. So let's go to the next one here. So North American QuitLine Consortium sort of is a nonprofit membership organization and based out of Phoenix, Arizona. And they, as an organization, or we as an organization, I should say, because most of the states are members of it, want to promote evidence-based QuitLine services across the diverse communities in the United States, in North America, basically, because Canada is actually participating in this consortium as well. So, bottom line today, residents of all 10 provinces in 2 territories in Canada, Mexico, all United States, Puerto Rico, Guam, District of Columbia, all have access to QuitLine services, internationally speaking as well, but we'll stick with North America right now. With relatively little investment, tobacco treatment programs are available through your state QuitLine, so I really encourage you to get on your state, if you're not going to, I wouldn't bother with the phone call first, but, get on your state health department's website and click on tobacco, for, health department, and go to, they usually have listed topics listed A through Z, go on to that, under tobacco, and more than likely you'll find information about the state QuitLine. If not, you can click around and you're going to find it somewhere because every state health department in their tobacco control program is funded to promote or to have a QuitLine. So some of the QuitLines are funded. Most of the QuitLines is multiple funding, so it's state funding, it's federal funding, and many of the states have saved master settlement agreement money, which was the lawsuit between the United States and the tobacco companies way back in 1998, have put money aside, so it's funded with that too. So QuitLines, they serve anybody with some exceptions. So in New Hampshire, I'll speak for New Hampshire. So New Hampshire, anybody who calls. Some states choose only the Medicaid population and the uninsured. So if you have Blue Cross Blue Shield and you call your QuitLine in state A, let's just say that, what may happen is when they do the intake and name, address, insurer for their database, and you say, I have Anthem, they'll say, well, Anthem provides a cessation benefit for all their members. I'm going to connect you with your health plan. And that's what we call a warm transfer back to the health plan. In New Hampshire, we don't happen to do that, but there are many states who don't fund it, so they sort of consider it double dipping should you access state free services as well when your health plan offers those same services of some sort. So we'll go to the next slide, which talks about, there we go. So let's just talk a little bit about the actual intervention, the brief intervention. And the book I showed you, Public Health Service Guidelines, a few slides earlier, speaks to the 5 A's. So you ask, identify your patient, you advise them for the best thing for their health, assess their readiness to talk about it and assist their efforts, and then arrange for a follow-up. So that's a lot to ask providers to put into their 15-minute appointments. So we sort of condensed that into 2 A's and an R. So in New Hampshire anyway, I'll speak for New Hampshire, we have what we call the Ask, Assist, and Refer protocol. And the intervention is basically to ask, and I've organized this so least likely to have a successful quit from a patient, somewhat likely, and most likely. So there is no, there's an ask, but it's not listed in the medical record. You can identify them, but is somewhat likely just have an interest in it and then most likely to quit, identify patients smoking at every single visit. Those two spots. Assist. You don't even have any assist at all, or you have you sort of have that judging or nagging or blaming attitude. Very, very likely that the person is going to just shut down and not want to talk about it, not even want to discuss the fact that they smoke. Somewhat likely 1 to 3 minutes of discussing the benefits of quitting, discussing the prognosis of not quitting, those kinds of things. Somewhat likely, but very likely to encourage them to make a quit attempt is to have a 3 to 5 minute intervention using some techniques we'll talk about in a few minutes, the motivational intervention techniques, the rating scale, and decisional balance, which are a little bit later. And then also the medications. Those who quit cold turkey, less than 5% actually succeed for long term. They're more likely, if they do succeed for short term, to relapse. And then the refer, which is the last line, no referral, least likely to have a quit attempt. Handing out print materials or a direct referral to what we call QuitWorks New Hampshire, but it's a direct referral to the state quit line. So highest success rates are going to be a combination of medication plus counseling for 100 to 300 minutes. So that's your highest success. The most likely to have somebody success. And that's a lot to ask for providers to deliver. So for one stop, we have a polling question. So the polling question is, are you comfortable addressing tobacco use with your patients that use tobacco?
Teresa, you might just need to wait a little bit longer.
Oh, that's fine. That's fine. No problem.
To come up momentarily. Looks like they're up now.
Okay. So it looks like nobody's uncomfortable, which is awesome. But half of you didn't answer, so I'm not sure what's going on there. But the important piece of this is if to use this attitude of the person who's asking the question. And I like to say a nice way of asking, because obviously if they're still smoking or not, you can smell it on them, just to sort of go in from the back door and say, can you tell me if you're smoking more or less since or the same since the last time I saw you? And, often your answer will be, I'm smoking about the same. Great. You're not smoking more. That's a good thing. Is there anything I can do for you today that might help you to consider making a quit attempt today, or think about making a quit attempt, or on a scale of 1 to 10, how do you feel about making a quit attempt? So those are the kinds of things you want to think about. You also want to make sure that you're asking the person, can you tell me about how many you're smoking a day? I forgot from the last time, or I need to write it down, or whatever. And have a very soft discussion, and you may get a better response than ignoring it completely. Because after you leave an appointment, people kind of cogitate on what you've said. And if you leave them with a bad taste in their mouth of an attitude that is judging them or scolding them, they'll shut down. So this rating scale that is part of the motivational interviewing is a wonderful tool to assess their readiness. Are you, in your confidence, talk about your self-confidence. How confident are that you could make a quit attempt in the next month? And if they say, well, I'm a 3. Well, you're not a 1, you're not a 0. So what makes you a 3? And what could move you from a 3 to a 4. So you want to sort of go in from the back door, and you can ask different questions and use the rating scale. How confident are you that your quit attempt that you just told me you're going to make tomorrow, how confident are you that you'll be successful? And if they say, oh, I don't know, I'm not confident at all, well, I have some resources here that might help you be more confident or help you on your way. So, how confident are you, how willing are you to try nicotine replacement therapy? And we could talk about that a little bit. And just those soft approaches and being able to offer resources in a positive way is often very helpful. The second tool that's that is helpful in a motivational interviewing tool is your decisional balance table. And if you put this to memory, you can jot it down, or you can make a little table and have them keep it with them and have them jot things down over between now and the next time you see them. What's the best thing? Making changes, most of us don't consider all sides. So instead we often think, what we should do, we avoid things we don't feel like doing, or just feel confused and overwhelmed and then give it up. So to think about the pros and the cons of making a change and the pros and the cons of not making a change is sometimes helpful for people to really look at all sides of the issue. So again, think this is New Hampshire's face, but smokers are called the quit line. The one is a 1-800 number. Our website is the QuitWorks. The New Hampshire Tobacco Helpline is the lower box on the right-hand side. And this is for the general public. 1-800-QUIT-NOW, quitnownh.org. That's for the general public. And we encourage all of you to go on and look around and see what's offered on your own. I mean, you're looking to obviously go in New Hampshire, but, to go on your own. And like I said, I think if you can probably access it through your state health department's website itself. And the two services that are offered more than likely through every state, I think almost every single state offers two services through their helpline vendor or their quit line vendor, and that is a general public and then something specifically for providers. So if you look up at QuitWorks New Hampshire, which is the upper left corner, that's our provider-only website, and that has specific information that is relevant to providers. I wouldn't see the general public there, and that's the website I use when I talk to clinicians, healthcare providers, and social workers, and those types of professionals. About if you want to refer somebody, and you can see that little orange tab there, referral forms, and what Jen talked about was actually a referral form that can, what we call a direct referral, and send your patient from any kind of referral. Like instead of referring them to the cardiologist, you refer them to the helpline. Or instead of referring them to the podiatrist, you could refer them to your helpline. It's the same type of thing, and it can be done secure email. It can be done through your electronic health record. It can be done through the phone-type fax machine. So here's another polling question, and just to get a feel for, do you refer patients to your state quit line to sort of see if your state quit line is utilized? Okay, I think those are in. So it doesn't look like there's a lot of people using the quit line. So here's a form that New Hampshire has, and you can see the top part of the form is where the healthcare provider fills out who they are, where they're from. And so to make it easier, this is what I did for what I do for anybody who wants me to is I put their agency's logo on the form, and I pre-populate the form so they don't have to refill out the form every single time. And then the bottom part is for the patient information, and this form is faxed, like I said, faxed electronically. However, it gets to the QIT coaches at the other end of the, for the QIT line vendor it goes to the QIT coaches. And a QIT coach will typically call a patient back, reach out to a patient within 24 hours, and conduct an intake screener, and then offer coaching, counseling, and some kind of QIT plan. Some states offer nicotine replacement therapy medications through their QIT line. Some don't. We do, but we only offer patches. Some QIT lines offer patches, gum, lozenges, the whole 9 yards. We offer free nicotine replacement patches as well as 6 15-minute counseling sessions. So our QIT, and then of course Jen talked about this too. We do evaluate our outcomes because we keep a huge database, and our outcomes are based on 6 months of recontacting any patient who's gone through the program, recontacting them in 6 months after they were referred to say, were you satisfied with our services? Number one. Number two, have you been quit for 30 days or more in the past 30 days? And our quit rates for our patients run around 30%, which is pretty good. So just to give you an idea of what happens in detail, whether they call the Quit Now, which is a national portal. When I say national portal, I mean that if you have a 603 area code, which is New Hampshire, and you're in California, and you call 1-800-QUIT NOW and you're standing in California, but your phone has a 603 area code, you automatically be routed to the New Hampshire helpline. So it's based off your area code. Same thing if you're in, a California visiting New Hampshire, and you're standing in New Hampshire and you call 1-800-QUIT NOW, you'll get the California quit line. So it's all based off of that. You'll get the usual press 1 for English, press 2 for Spanish, and then you probably will get a live answer. How can I, New Hampshire Medical Helpline, how may I help you? And then they try to conduct a very short screener to find out some demographic information that goes into our database. And then they offer an opportunity to start counseling right then, or make a first counseling appointment that a quick coach will call you back. Say, my kids don't go to bed, I can't talk to anybody at 8 o'clock at night. My kids don't go to bed, and blah, blah, blah. So the quick coach simply says, okay, let's make a time to call you back after 8 p.m., and then they can start their counseling sessions. And like I said, we offer 6 in our program. We offer 6 counseling sessions. The first one tends to be about 30 to 45 minutes, depending on how chatty the people are. And then after that, it's 15 minutes progress checks. And if they do complete that first counseling call, they are sent 4 weeks of nicotine replacement patches based on the answers they've given about their addiction level. And then so hopefully, as they go through the counseling, they are coached, and they will stay quit. They can call back into the quit line if they just choose to only take 1 counseling session. That's fine. If they choose to take more, they can get more free patches. If they have a relapse, they're welcome to continue on with the coaching. We try to do as much as we can to make them as successful as possible, and they're of course encouraged to complete all 6. But life happens, and people feel like they're off on a really good running start. They may they may go off on their own and be very successful. So sort of in a nutshell, that's what it's all about. And I'm happy to take any questions. I'm going to turn it back over. I'm going to find how to do the ball.
Teresa, it's Olivia. Yep. You can just click and drag the ball back to me if you want.
I don't know. I don't see the ball on my screen. So
it's next to your name where it says participant.
Oh,
You can just grab it.
Okay, I
hold down.
I'm going back to you. Okay.
Perfect. Thank you.
Yes. There you go.
So I just want to open the line for anyone who may have some questions for Teresa or Jennifer. You can press #6 to open up your line, or you can press you can pose a question in the chat box. Just make sure if you do pose a question in the chat box, you're sending it to all participants. Again, #6, or you can send a question in the chat box to all participants. And while we're waiting for the questions, Georgette, are you still on the phone? Georgette, you just have to press #6 to unmute yourself.
Can you hear me now?
I can hear you now.
Okay, good. Yes, I am on the line. And I want to thank Teresa and Jennifer both for your presentations. And I see Olivia just put up our next slide. As you can see, there's someone with the QIN-QIO in every state here in New England that you can reach out to. We're here to help you. I know home health agencies are very strapped these days and can use all the resources they can get. So we're happy to help you with the smoking cessation program or anything else that you might be interested in.
So again, if you don't have any questions at the current moment, you can always email questions to Georgette, whose email is up here, or any of the other home health leads. And I just want to thank, sorry?
Okay, I was going to say, it's looking like we're not getting any questions right now. I don't know if Jen or Teresa have anything else they'd like to add.
Can you hear me?
Yeah.
Yes, I can.
Okay. No, I don't have anything further to add.
I could talk forever, but I will say right this minute I'm all set. I hope this is helpful, and I really hope people out there understand how valuable a resource their state quit line is, and refer and promote the use of their state quit line.
And I'd also add, if anybody wants to reach out to me directly to find out more about, some challenges or barriers, if they have a specific question, I'm okay with that as well.
Thank you.
Thanks. Georgette, I just have a few last-minute announcements before we end the call. Do you have anything else you'd like to add before I say those?
No, I think we're all set, Olivia. Thanks so much to everybody who's attended and for those panelists that we've had on.
Awesome. I just want to thank everyone again, Georgette and Teresa and Jen. And again, I just have a few last-minute announcements. When you close out of this webinar, the evaluation will automatically pop up on your computer. You can fill that out. We would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow morning with the link to the evaluation, as well as the link to the event page on our website. The PowerPoint presentation is already posted on our website, and within a few business days, a recording and a transcript will be added. And be on the lookout for emails about our next webinar. And thanks again for attending, and have a great day. Thanks, everyone.
Thank you. Bye.
Bye.
The leader has disconnected. The conference will